Question 1. A 68-year-old male presents to the emergency department with severe abdominal pain, nausea, and vomiting. Diagnostic imaging reveals acute cholecystitis with cholelithiasis. The patient is admitted for surgical removal of the gallbladder. What is the correct sequencing of the diagnoses? A. Cholelithiasis, acute cholecystitis. B. Acute cholecystitis, cholelithiasis. C. Abdominal pain, acute cholecystitis, cholelithiasis. D. Cholelithiasis with obstruction, acute cholecystitis. Answer: B. Acute cholecystitis, cholelithiasis. This question tests the sequencing of diagnoses when a condition, cholelithiasis, causes another acute condition, cholecystitis. When a patient has both cholelithiasis, gallstones, and cholecystitis, inflammation of the gallbladder, and the cholelithiasis is causing the cholecystitis, the acute cholecystitis is sequenced as the principal diagnosis because it is the main reason for the encounter, followed by the cholelithiasis. Acute cholecystitis describes the severity and urgency of the patient's current condition. Remember, always code the acute condition first when documentation indicates it is due to an underlying chronic condition, unless specific guidelines dictate otherwise. Question 2. A patient with type 2 diabetes mellitus is admitted to the hospital with diabetic ketoacidosis, DKA, and hyperosmolarity. The patient also has diabetic retinopathy. Which codes are appropriate for the principal diagnosis and coexisting conditions? A. E11.65, type 2 diabetes mellitus with ketoacidosis, E11.00, type 2 diabetes mellitus with hyperosmolarity without non-ketotic hyperglycemic hyperosmolar coma, E11.31, type 2 diabetes mellitus with proliferative diabetic retinopathy. B. E11.65, type 2 diabetes mellitus with ketoacidosis, E11.31, type 2 diabetes mellitus with proliferative diabetic retinopathy. C. E11.10, type 2 diabetes mellitus with ketoacidosis without coma, E11.01, type 2 diabetes mellitus with hyperosmolarity with coma, E11.31, type 2 diabetes mellitus with proliferative diabetic retinopathy. D. E11.65, type 2 diabetes mellitus with ketoacidosis, E11.31, type 2 diabetes mellitus with proliferative diabetic retinopathy, E11.00, type 2 diabetes mellitus with hyperosmolarity without non-ketotic hyperglycemic hyperosmolar coma. Answer: A. E11.65, type 2 diabetes mellitus with ketoacidosis, E11.00, type 2 diabetes mellitus with hyperosmolarity without non-ketotic hyperglycemic hyperosmolar coma, E11.31, type 2 diabetes mellitus with proliferative diabetic retinopathy. This question evaluates the proper coding and sequencing of multiple diabetes manifestations. When a patient has multiple complications of diabetes, such as ketoacidosis and hyperosmolarity, both should be coded if present, along with other existing complications like retinopathy. The key is to code each distinct manifestation that is documented and clinically supported, with the principal diagnosis being the condition that brought the patient to the hospital. For example, in this case, DKA is the primary reason for admission, so E11.65 is primary, followed by E11.00 for hyperosmolarity, and E11.31 for the retinopathy. Always ensure that all documented manifestations contributing to the patient's care are captured. Question 3. A 45-year-old patient undergoes an open radical prostatectomy with bilateral pelvic lymphadenectomy for prostate cancer. Which CPT codes should be reported? A. 55840, 38571. B. 55840, 38562. C. 55840. D. 55845. Answer, C. 55840. This question tests the understanding of CPT code bundling for complex procedures. The key here is the term radical prostatectomy and bilateral pelvic lymphadenectomy. CPT code 55840, which describes an open radical prostatectomy, already includes the pelvic lymphadenectomy when performed as part of the radical prostatectomy. Therefore, it is inappropriate to report the lymphadenectomy separately with a distinct code. Always review the CPT code descriptions and parenthetical notes carefully to ensure that components of a primary procedure are not unbundled and reported separately. Question 4. A patient is seen for a follow-up visit after a recent myocardial infarction, MI, and is prescribed new medication. The documentation states the patient is stable. The provider performs a detailed history and detailed examination and determines medical decision-making, MDM, is of moderate complexity. What is the correct E/M code for this visit? A. 99,213. B. 99,214. C. 99,215. D. 99,203. Answer, B. 99214. This question assesses the correct E/M code selection for an established patient visit based on the documented components. For established patient E/M services, 99,212 to 99,215, code selection is primarily driven by the level of medical decision-making, MDM, or total time spent on the encounter on the date of service. In this scenario, the MDM is stated as moderate, and while history and exam components are mentioned, MDM is the key factor for code selection in an established patient outpatient visit since 2021. Therefore, a moderate MDM aligns with CPT code 99214. Remember to prioritize MDM or total time for office/outpatient E/M services, as history and exam are no longer required to meet a specific level for code selection. Question 5. A patient presents with a laceration to the arm due to a fall. The documentation states the fall occurred at home, but there is no specific external cause code in the medical record. What is the coder's responsibility? A. Assign W01.XXXA for fall on same level, unspecified. B. Assign Y92.009 for unspecified place of occurrence, home. C. Assign W19.XXXA for unspecified fall, and Y92.009 for unspecified place of occurrence. D. Do not assign an external cause code as the specific circumstances are not documented. Answer, C. Assign W19.XXXA for unspecified fall, and Y92.009 for unspecified place of occurrence. This question tests the guideline for coding external causes when specific details are missing. Even if the specific mechanism of the fall, e.g., slipping, tripping, is not documented, an external cause code for an unspecified fall, W19.XXXA, should be assigned if the external cause is known to exist. Additionally, the place of occurrence, Y92.009 for unspecified place in a residence, should be coded when known. Coders should always strive to assign the most specific code supported by documentation, but if details are missing, unspecified codes for both the external cause and place of occurrence should still be reported when an external cause event is clearly indicated. Question 6. A patient is admitted for elective surgery. During the preoperative workup, it is discovered the patient has asymptomatic bacteriuria. The surgeon decides to proceed with the surgery as planned, and the bacteriuria is treated post-operatively. What is the correct coding for the bacteriuria? A. Code bacteriuria as a secondary diagnosis, as it was treated. B. Do not code bacteriuria, as it was asymptomatic and did not affect the surgery. C. Code bacteriuria as a principal diagnosis, as it was discovered and treated during the admission. D. Code bacteriuria as an other diagnosis if it meets the definition of a reportable condition. Answer: D. Code bacteriuria as an other diagnosis if it meets the definition of a reportable condition. This question assesses the reporting of coexisting conditions that are discovered during an inpatient stay. Asymptomatic bacteriuria is generally not coded unless it meets the definition of an other diagnosis, meaning it requires clinical evaluation, therapeutic treatment, diagnostic procedures, extended length of hospital stay, or increased nursing care and monitoring. Since it was discovered and treated postoperatively, it meets the definition of a reportable other diagnosis because it required therapeutic treatment. Always review the other diagnosis definition in the official guidelines for coding and reporting to determine if a condition should be coded. Question 7. A patient undergoes an initial inpatient hospital stay for pneumonia. During the admission, the patient develops sepsis due to the pneumonia and is transferred to the critical care unit. The patient recovers and is discharged home. What is the correct sequencing of diagnoses? A. Sepsis, pneumonia. B. Pneumonia, sepsis. C. Pneumonia, severe sepsis. D. Sepsis, severe sepsis, pneumonia. Answer: A. Sepsis, pneumonia. This question tests the sequencing of codes for sepsis that develops during an inpatient admission. According to the official guidelines for coding and reporting, if sepsis develops during an admission and meets the definition of a principal diagnosis, it should be sequenced as the principal diagnosis, followed by the underlying infection. In this case, the pneumonia led to the development of sepsis, making sepsis the principal diagnosis. Always remember that when sepsis develops from an infection during a hospitalization, the sepsis code typically takes precedence as the principal diagnosis. Question 8. A surgeon performs an open repair of an incarcerated incisional hernia with insertion of mesh. What is the correct CPT code? A. 49560. B. 49561. C. 49565. D. 49566. Answer: D. 49566. This question focuses on specific CPT coding for hernia repairs, particularly involving incarceration and mesh. The correct code for an open incisional hernia repair that is incarcerated is 49566, which specifically includes the repair of an incarcerated or strangulated incisional hernia. The insertion of mesh is reported with an add-on code, plus 49568. However, among the given choices, 49566 is the most accurate for the incarcerated repair itself. Always pay close attention to terms like incarcerated or strangulated, as they often lead to more specific and higher-level codes for hernia repairs. Question 9. A patient presents with acute on chronic systolic, congestive, heart failure. Which ICD-10-CM code should be assigned? A. I50.21, I50.22. B. I50.23. C. I50.20, I50.21. D. I50.23, I50.22. Answer: B. I50.23. This question tests the understanding of combination codes for heart failure. When documentation indicates acute on chronic systolic, congestive, heart failure, a single combination code is used to capture both the acute and chronic components. The code I50.23 specifically represents acute on chronic systolic, congestive, heart failure. It is important to avoid separate codes for acute and chronic if a combination code exists, as this could lead to incorrect coding and billing. Always look for a single code that fully describes the condition, if available. Question 10. A patient is admitted for a total knee arthroplasty, TKA. Postoperatively, the patient develops a localized seroma at the surgical site, which requires incision and drainage. What is the correct coding for the seroma and its treatment? A. T81.89XA, other complications of procedures, not elsewhere classified, J95.89, other specified disorders of respiratory system, not elsewhere classified. B. T81.89XA, other complications of procedures, not elsewhere classified, and a code for incision and drainage. C. L76.01, intraoperative hemorrhage and hematoma of skin and subcutaneous tissue complicating a procedure, followed by a code for incision and drainage. D. Do not code the seroma if it was drained as part of routine postoperative care. Answer. B. T81.89XA, other complications of procedures, not elsewhere classified, and a code for incision and drainage. This question assesses the coding of postoperative complications requiring intervention. A seroma, which is a collection of fluid, developing after surgery, is considered a complication of a procedure. Since it's a localized seroma and requires incision and drainage, it's a reportable complication and not part of routine care. T81.89XA is the appropriate code for other complications of procedures, not elsewhere classified. A separate CPT code would then be assigned for the incision and drainage procedure. Always code documented complications that impact patient care or require additional intervention. Question 11. A 70-year-old patient undergoes an excisional biopsy of a palpable breast mass in the upper outer quadrant of the right breast. Pathology reveals atypical ductal hyperplasia. What is the correct ICD-10-CM code for this encounter? A. N63.11, unspecified lump in right breast, upper outer quadrant. B. D48.6, neoplasm of uncertain behavior of breast. C. N60.8, other specified benign mammary dysplasias. D. N60.31, fibrosclerosis of breast, right breast. Answer. C. N60.8, other specified benign mammary dysplasias. This question tests the correct coding for a benign breast condition found after a biopsy. The patient presented with a mass, N63.11 initially, but the pathology result, atypical ductal hyperplasia, is the definitive diagnosis after the excisional biopsy. Atypical ductal hyperplasia is a form of benign mammary dysplasia, and the most appropriate code for this specific diagnosis is N60.8, other specified benign mammary dysplasias. Do not code the lump, N63.11, once a definitive diagnosis has been established. Always code to the highest level of specificity based on the final pathology report. Question 12. A patient is admitted for elective surgery for a fractured humerus. Pre-admission testing reveals controlled hypertension, which is documented and managed throughout the stay. The hypertension does not significantly affect the length of stay or the care provided. How should the hypertension be coded? A. As the principal diagnosis. B. As a secondary diagnosis. C. Not coded, as it is a pre-existing condition and did not affect the surgery. D. Only coded if medications were adjusted during the stay. Answer. B. As a secondary diagnosis. This question assesses the guideline for coding coexisting conditions in an inpatient setting. Even if a chronic condition like controlled hypertension does not significantly affect the length of stay or directly impact the surgery, it should still be coded as a secondary diagnosis if it is documented as being clinically evaluated, assessed, or managed during the inpatient admission. The fact that it was documented and managed throughout the stay indicates clinical significance. Always code all conditions that affect patient management during the encounter, even if they are stable. Question 13. A patient presents with a painful, swollen knee. After examination and X-rays, the physician diagnoses acute osteomyelitis of the right knee. Which code is most appropriate? A. M86.871, other osteomyelitis, right lower leg. B. M86.851, other osteomyelitis, right thigh. C. M86.271, subacute osteomyelitis, right lower leg. D. M86.279, subacute osteomyelitis, unspecified lower leg. Answer A. M86.871, other osteomyelitis, right lower leg. This question requires precise anatomical site coding within the musculoskeletal chapter. The knee joint, in the context of ICD-10-CM, is generally considered part of the lower leg for osteomyelitis coding purposes, specifically referring to the lower end of the femur, upper end of the tibia/fibula, and patella. Therefore, M86.871, other osteomyelitis, right lower leg, is the correct choice, even though the specific bone isn't mentioned, as it represents the larger anatomical region that includes the knee. Pay close attention to the anatomical groupings in the tabular list, as they may differ from common medical terminology. Question 14. A patient undergoes an MRI of the brain without contrast. Later on the same day, due to further findings, the patient undergoes another MRI of the brain, this time with contrast. How should these services be reported? A. 70551, 70553. B. 70551, 70552 with modifier 59. C. 70553. D. 70551, 70552. Answer C. 70553. This question tests the CPT guidelines for imaging studies performed with and without contrast on the same day. According to CPT guidelines, if an MRI study is performed both without contrast and then with contrast on the same body part during the same encounter, only the code for the study with and without contrast should be reported. In this case, 70553 represents magnetic resonance, MR, imaging, brain, with and without contrast materials. It is inappropriate to report the without contrast study separately when a combination code exists. Always look for combination codes when both with and without contrast studies are performed. Question 15. A 55-year-old male is undergoing treatment for stage 3 chronic kidney disease, CKD. He presents with severe fatigue and labs confirm anemia due to the CKD. He receives an injection of erythropoietin. Which diagnosis codes should be reported? A. N18.3, chronic kidney disease, stage 3, D63.1, anemia and chronic kidney disease. B. N18.3, chronic kidney disease, stage 3, D64.9, anemia, unspecified. C. D63.1, anemia and chronic kidney disease, N18.3, chronic kidney disease, stage 3. D. N18.3, chronic kidney disease, stage 3. Answer A. N18.3, chronic kidney disease, stage 3, D63.1, anemia and chronic kidney disease. This question addresses the specific coding guideline for anemia and chronic kidney disease, CKD. When a patient has both CKD and anemia due to the CKD, it is required to code both conditions. The anemia due to CKD is an integral part of the CKD itself, so the specific code for anemia and CKD, D63.1, should be used, not an unspecified anemia. While the CKD is the underlying cause, the anemia is a significant manifestation requiring treatment. The sequencing depends on the reason for the encounter, but if both are treated, both are reported. Question 16. A patient is admitted for inpatient hospice care due to terminal lung cancer. The patient also has documented chronic obstructive pulmonary disease, COPD. How should the lung cancer and COPD be coded for the hospice admission? A. Lung cancer as principal, COPD as secondary. B. COPD as principal, lung cancer as secondary. C. Only the lung cancer, as it is the terminal diagnosis. D. Both conditions, but only the lung cancer is eligible for hospice reimbursement. Answer A. Lung cancer as principal, COPD as secondary. This question tests the coding guidelines for hospice admissions. For hospice encounters, the principal diagnosis should be the condition that is the terminal diagnosis or the primary reason for hospice admission, which in this case is lung cancer. Any coexisting conditions, like COPD, that are documented and managed during the hospice stay should be reported as secondary diagnoses, even if they are not the reason for the terminal prognosis. Always ensure the principal diagnosis reflects the condition directly leading to hospice care. Question 17. A physician documents uncontrolled type 2 diabetes mellitus. The patient's blood glucose levels are consistently high, but there is no documentation of specific complications such as ketoacidosis or hyperosmolarity. Which code should be assigned? A. E11.9, type 2 diabetes mellitus without complications. B. E11.65, type 2 diabetes mellitus with ketoacidosis. C. R73.03, prediabetes. D. E11.69, type 2 diabetes mellitus with other specified complication. Answer A. E11.9, type 2 diabetes mellitus without complications. This question highlights a common pitfall in diabetes coding related to uncontrolled status. In ICD-10-CM, the term uncontrolled or poorly controlled is not recognized as a specific complication itself. If the documentation only states uncontrolled diabetes without specifying a related complication, like ketoacidosis, hyperosmolarity, or chronic complications becoming acute, the appropriate code is E11.9, type 2 diabetes mellitus without complications. Do not assume or assign a complication code unless it is explicitly documented. Question 18. A patient presents for a scheduled colonoscopy screening. During the procedure, the physician identifies and removes a small sessile polyp from the sigmoid colon by hot biopsy forceps. What CPT codes should be reported? A. For 5378, for 5384. B. 45,384. C. G0121, for 5384. D. 45,385. Answer B. For 5384. This question tests the correct coding for a screening colonoscopy that becomes diagnostic and therapeutic. When a screening colonoscopy, G0121, identifies a lesion and a biopsy or removal, like hot biopsy forceps, for 5384, is performed during the same encounter, only the therapeutic CPT code, for 5384 in this case, should be reported for Medicare patients. The hot biopsy forceps method is a type of endoscopic excision. The screening code G0121 is not reported when a therapeutic procedure is performed during the same colonoscopy. For non-Medicare payers, you might report 45384. Question 19. A patient is undergoing chemotherapy for lung cancer. During the infusion, the patient experiences severe nausea and vomiting due to the chemotherapy. Which is the correct principal diagnosis for this encounter? A. Nausea and vomiting, R11.2. B. Malignant neoplasm of lung, C34.90. C. Adverse effect of antineoplastic and immunosuppressive drugs, T45.1x5A. D. Encounter for antineoplastic chemotherapy, Z51.11. Answer: D. Encounter for antineoplastic chemotherapy, Z51.11. This question tests the principal diagnosis sequencing for chemotherapy encounters with complications. When a patient is admitted for chemotherapy and experiences a complication, like severe nausea and vomiting, during the administration, the principal diagnosis should be the reason for the admission, which is the chemotherapy, Z51.11. The complication, nausea/vomiting, and the adverse effect of the chemotherapy, T45.1x5A, are reported as secondary diagnoses. The primary focus of the encounter is the chemotherapy itself. Question 20. A patient is brought to the emergency department after sustaining multiple fractures in a motor vehicle accident. The patient has an open fracture of the tibia and fibula, and a closed fracture of the femur. Which fracture should be sequenced as principal? A. The open fracture of the tibia and fibula. B. The closed fracture of the femur. C. Whichever fracture required the most significant intervention. D. The fracture that poses the greatest threat to life. Answer: A. The open fracture of the tibia and fibula. This question assesses the sequencing guidelines for multiple traumatic injuries. When a patient sustains multiple fractures, and one is specified as open and another as closed, the open fracture should generally be sequenced as the principal diagnosis. Open fractures carry a higher risk of complications, like infection, and often require more immediate and complex management. For example, the open fracture of the tibia and fibula requires immediate attention to prevent infection, making it the principal reason for the encounter. Always prioritize the more severe or complex injury when determining the principal diagnosis in trauma cases. Question 21. A patient presents for excision of a skin lesion. The documentation states lesion on the left arm, suspicious for melanoma. The physician excises the lesion. The pathology report later confirms it is a benign nevus. What is the correct diagnosis codes for this encounter? A. D22.61, melanocytic nevi of left upper limb, including shoulder. B. C43.61, malignant melanoma of skin of left upper limb, including shoulder. C. Z85.820, personal history of melanoma. D. D22.61, Z85.820. Answer: A. D22.61, melanocytic nevi of left upper limb, including shoulder. This question highlights coding based on definitive pathology results versus initial clinical suspicion. Even though the lesion was initially suspicious for melanoma, the definitive pathology report confirmed it as a benign nevus. Therefore, the benign diagnosis code D22.61 for the melanocytic nevus of the left upper limb should be assigned. You always code the definitive diagnosis documented by the pathology report, not the signs, symptoms, or suspected diagnoses, unless specific guidelines for uncertain diagnoses apply, which is usually for inpatient encounters and specific conditions. Question 22. A patient undergoes an ultrasound of the breast for a suspicious finding identified on a prior mammogram. The ultrasound reveals a simple cyst. What is the correct ICD-10-CM code for the ultrasound encounter? A. R92.8, other abnormal and inconclusive findings on diagnostic imaging of breast. B. N60.0, solitary cyst of breast. C. Z12.31, encounter for screening mammogram. D. R92.0, mammographic microcalcification. Answer, B. N60.0, solitary cyst of breast. This question tests the guideline for coding diagnostic encounters where the reason for the test is a suspicious finding that then leads to a definitive diagnosis. The initial abnormal mammogram finding, R92.8, prompted the ultrasound. However, the ultrasound provided a definitive diagnosis, a simple cyst. Therefore, the definitive diagnosis of the simple cyst, N60.0, should be reported as the primary diagnosis, as it is the final confirmed condition. Do not code the abnormal finding, R92.8, if a definitive diagnosis is established. Question 23. A patient is admitted for inpatient rehabilitation following a stroke that occurred 3 weeks prior. The patient is no longer experiencing acute symptoms of the stroke. What is the appropriate principal diagnosis for this admission? A. I63.9, cerebral infarction, unspecified. B. I69.351, hemiplegia and hemiparesis following cerebral infarction affecting right dominant side. C. Z51.89, encounter for other specified aftercare. D. Z51.89, I69.351. Answer, B. I69.351, hemiplegia and hemiparesis following cerebral infarction affecting right dominant side. This question addresses the coding of late effects/sequelae of a cerebrovascular accident, CVA, for rehabilitation. When a patient is admitted for rehabilitation due to the residual effects, sequelae, of a past stroke, the sequela code is sequenced as the principal diagnosis, followed by the stroke code, I69.XXX. The patient is specifically admitted for the hemiplegia following the stroke. The specific sequela, such as hemiplegia, I69.351, should be the principal diagnosis, with the history of the stroke, I63.9 or similar, if still relevant for additional data, as a secondary diagnosis, if applicable. Question 24. A patient with a history of recurrent urinary tract infections, UTIs, presents to the clinic with symptoms suggestive of a new UTI. A urine culture is ordered. The provider documents suspected UTI. The patient is started on empiric antibiotics. What is the correct ICD-10-CM code for this encounter? A. N39.0, urinary tract infection, site not specified. B. R30.0, dysuria. C. Z87.440, personal history of urinary tract infection. D. R39.81, nocturia. Answer, A. N39.0, urinary tract infection, site not specified. This question tests the coding of suspected conditions in an outpatient setting where treatment is initiated. In the outpatient setting, if a diagnosis is suspected but not confirmed, and treatment is initiated, you generally code the signs, symptoms, or the confirmed diagnosis. However, for a suspected UTI where empiric antibiotics are started, it is common practice to code the condition as if it exists, N39.0, because treatment has been initiated. If no treatment were initiated and only labs ordered, then the symptoms would be coded. Always clarify with the provider if uncertain. Question 25. A patient undergoes repair of a complete rotator cuff tear, open approach. The surgeon also performs an acromioplasty as part of the procedure to allow adequate space for the repair. What CPT codes should be reported? A. 29,827. B. 23,412. C. 23412, 29826 to 59. D. 23412, 23415. Answer B. 23412. This question assesses the bundling of procedures in CPT coding. When an acromioplasty is performed as part of an open rotator cuff repair, it is considered an integral component of the rotator cuff repair and is not separately reported. CPT code 23412, repair of rotator cuff, e.g., torn supraspinatus, infraspinatus, or subscapularis, open, complete tear, encompasses any necessary reshaping of the acromion to facilitate the repair. Therefore, only 23412 should be reported. Always check the NCCI edits and CPT guidelines to avoid unbundling services that are inherent to a primary procedure. Question 26. A patient is admitted to the hospital with acute respiratory failure. The patient also has documented end-stage chronic obstructive pulmonary disease, COPD, and type 2 diabetes. The physician states that the acute respiratory failure is due to an exacerbation of the COPD. What is the correct sequencing of diagnoses? A. J96.00, acute respiratory failure, unspecified, J44.1, chronic obstructive pulmonary disease with acute exacerbation, E11.9, type 2 diabetes mellitus without complications. B. J44.1, chronic obstructive pulmonary disease with acute exacerbation, J96.00, acute respiratory failure, unspecified, E11.9, type 2 diabetes mellitus without complications. C. J96.00, acute respiratory failure, unspecified, J44.9, chronic obstructive pulmonary disease, unspecified, E11.9, type 2 diabetes mellitus without complications. D. J44.1, chronic obstructive pulmonary disease with acute exacerbation, E11.9, type 2 diabetes mellitus without complications. Answer A. J96.00, acute respiratory failure, unspecified, J44.1, chronic obstructive pulmonary disease with acute exacerbation, E11.9, type 2 diabetes mellitus without complications. This question tests the sequencing of acute respiratory failure when linked to another condition. When acute respiratory failure is documented as being caused by or associated with another condition, like COPD exacerbation, the acute respiratory failure is sequenced as the principal diagnosis. Therefore, J96.00 is principal, followed by J44.1 for the COPD with acute exacerbation, and then E11.9 for the diabetes. The acute respiratory failure is the more severe condition requiring immediate attention and is the primary reason for the patient's admission. Question 27. A patient presents to the urgent care clinic with a dog bite to the left hand. The bite is superficial and is cleaned and dressed. The patient is advised on wound care. Which external cause code should be assigned? A. W54.0XXA, bitten by dog, initial encounter. B. W54.1XXA, struck by dog, initial encounter. C. W54.0XXD, bitten by dog, subsequent encounter. D. W54.0XXX, bitten by dog, unspecified encounter. Answer A. W54.0XXA, bitten by dog, initial encounter. This question assesses the appropriate use of external cause codes and their seventh character. For a dog bite, the code W54.0XXA is specific for bitten by dog. The A seventh character indicates an initial encounter, which is appropriate for a patient presenting to the urgent care clinic for treatment of a new injury. It's crucial to select the correct activity, place, and status codes if available, and always include the appropriate seventh character to indicate the encounter type. Question 28. A patient is admitted for chemotherapy for metastatic bone cancer originating from the breast. The chemotherapy is administered. Which diagnosis code should be sequenced as principal and secondary? A. C79.51, secondary malignant neoplasm of bone, C50.919, malignant neoplasm of unspecified site of unspecified female breast, Z51.11, encounter for antineoplastic chemotherapy. B. Z51.11, encounter for antineoplastic chemotherapy, C79.51, secondary malignant neoplasm of bone, C50.919, malignant neoplasm of unspecified site of unspecified female breast. C. C50.919, malignant neoplasm of unspecified site of unspecified female breast, C79.51, secondary malignant neoplasm of bone, Z51.11, encounter for antineoplastic chemotherapy. D. Z51.11, encounter for antineoplastic chemotherapy, C50.919, malignant neoplasm of unspecified site of unspecified female breast, C79.51, secondary malignant neoplasm of bone. Answer: B. Z51.11, encounter for antineoplastic chemotherapy, C79.51, secondary malignant neoplasm of bone, C50.919, malignant neoplasm of unspecified site of unspecified female breast. This question tests the principal diagnosis for chemotherapy admissions and the sequencing of primary and secondary malignancies. When a patient is admitted solely for chemotherapy, the code Z51.11, encounter for antineoplastic chemotherapy, is always sequenced as the principal diagnosis. Following that, the code for the secondary malignancy, C79.51 for metastatic bone cancer, is sequenced, and then the code for the primary malignancy, C50.919 for breast cancer, is reported. Remember, the primary malignancy is generally coded after the secondary site, unless specific guidelines apply, e.g., if the primary is still active and the reason for the encounter is treatment of the primary. Question 29. A surgeon performs an arthroscopic meniscectomy of the lateral meniscus of the left knee. The documentation also states removal of loose bodies. What is the correct CPT codes? A. 29881. B. 29881, 29874. C. 29880. D. 29880, 29874-59. Answer: A. 29881. This question assesses the bundling of services within arthroscopy codes. CPT code 29881 describes an arthroscopy, knee, surgical, with meniscectomy, semilunar cartilage, medial or lateral. The key here is that removal of loose bodies, when performed in the same compartment as a meniscectomy, is considered an integral part of the meniscectomy procedure and is not separately billable. Therefore, only 29881 is reported. Always refer to CPT instructional notes and NCCI edits, which indicate that many minor procedures performed during the same arthroscopy are bundled into the primary surgical procedure. Question 30. A patient presents for excision of a sebaceous cyst on the back, measuring 2.5 centimeters. The physician documents a simple excision. What CPT code is appropriate? A. 11403. B. 11403, 12032. C. 11603. D. 11404. Answer: A. 11403. This question tests the correct CPT code for benign lesion excisions based on size and location. A sebaceous cyst is a benign lesion. CPT code 11403 is for excision, benign lesion, trunk, arms, or legs, excised diameter 2.1 to 3.0 centimeters. The measurement of 2.5 centimeters falls within this range. It's crucial to remember that for lesion excisions, the excised diameter includes the lesion plus the narrowest margin of normal skin required for complete excision. Also, be sure to use the correct anatomical site code series, 11400 for benign, 11600 for malignant.